Dr. Ruth Watkinson is a research fellow in the NIHR Applied Research Collaboration Greater Manchester at the University of Manchester. Her research uses large data sets to identify and understand socio-demographic health inequalities. Current projects include investigations of inequalities in vaccine uptake between socioeconomic and ethnic groups and inequalities in mental health outcomes amongst the LGBTQ+ community. Before joining the University of Manchester, Ruth worked in biomedical research in Cambridge and New York and studied for a Master's in Public Health at the London Science of Hygiene and Tropical Medicine. So should we give a round of applause for Ruth?
All right, thanks for the invitation. It's great to be here talking to you today. So, what's the question about? Yes. So the organisers suggested that I just give you a bit of an overview of my career and my kind of journey in research so far, just to give you a sense of kind of where I'm coming from and the kind of stuff that I've been doing. So I've been really lucky, and my career has taken me to quite a lot of interesting places around the world. But it actually started also right here. So I came to Manchester University to do undergraduate biochemistry, and as part of that course, there was an opportunity that came up to move to Florida for a year and work in one of the research labs at the Mayo Clinic Hospital. And that was an incredible opportunity. It was kind of cushy because we got paid for a year, but it was also just like a really great chance to get some hands-on lab research experience. And it really opened my mind to the possibility of a career in research. It was perhaps a bit naive, but it wasn't really something that I knew existed as a kind of viable career option. So from there, when I came back to Manchester for my final year, I decided to apply for PhDs, because if you want to be in research, that's often a good route to go. So it's an extra degree after you've done your undergraduate, and it's kind of very research focused. So it's a bit more like having a job. It's very much on the job kind of learning. So I worked in a lab that was researching viruses and immune responses. From there, it was around 2014, which you might remember is when the West African Ebola outbreak occurred. So this was the biggest outbreak that had ever happened, and it really spiraled out of control and became a full epidemic, and several countries in West Africa were really, really hard hit. So they kind of put out various requests for international help to try and bring the epidemic under control. So as part of that, they needed scientists who had experience working with viruses to come out and help set up diagnostic labs. So I volunteered to go out to Sierra Leone, and I was with a team in McKinney, and we helped establish a kind of temporary lab that was then, we ran kind of blood tests to diagnose Ebola, and also helped train up local staff to try and build capacity for local testing. So from there, the next thing I did, I applied for a fellowship, which allowed me to move to New York. And I worked in one of the research labs at Mount Sinai Hospital. So again, I was doing kind of virus research and working on viruses kind of with epidemic and pandemic potential. But I think as I was there, I was really enjoying the lab work that I was doing and things. But I also just kind of, I think my experiences in Sierra Leone and then also in New York, I was kind of reflecting more and more on kind of what does shape health? What is the most important thing? And I think, you know, as much as biomedical advances are important, there's so much in terms of the social world that we all live in and kind of the social opportunities that each of us have that shapes our health. And I think I gradually just started to be more interested in that side of research and that side of kind of what shapes our health and our health outcomes and access to healthcare. So from there, I then moved back to the UK, and I spent a year at the London School of Hygiene and Tropical Medicine studying public health. And then I moved back to Manchester, and I'm now working again at the university as a researcher in public health and health economics. So what I do now is I'm out of the lab and I use kind of big data sets and do kind of statistical analysis to try and understand what is it that causes and drives and explains these big health inequalities between different social and demographic groups. So that's a bit of an overview of kind of where I've been. Here's just a quick overview of some of the recent projects that we've been doing while I've been at Manchester the last few years. So this first one is a paper that we published looking at ethnic inequalities in health-related quality of life amongst older adults. So this was using a big national survey, which is actually the same survey I'll be talking about in detail later. And we found these really wide inequalities, particularly between some ethnic groups. A different kind of project that we've been doing was using NHS health records. So this was looking at inequalities in terms of who waits the longest in A&E to get treatment, and then do they get the right kind of treatment. And we found that patients who live in more deprived areas actually wait longer for care and tend to get less kind of expensive treatment compared to other patients who live in maybe in more affluent areas, but who are presenting with the same severity of conditions. Another paper that we did quite recently was looking at the COVID vaccine uptake. And again, I think you're probably aware of this from kind of national news stories, but we found evidence of really quite wide inequalities in uptake between different ethnic groups looking locally in Greater Manchester. And then a kind of related piece of work that we did, this was working with some analysts from NHS England who reached out to say they'd like some support with trying to evaluate how effective the rollout of the COVID vaccines has been at preventing hospitalisations in England. So that's a bit of a kind of variety of things that we do. Obviously, they're all different topics, they're different kinds of approaches. Some use health records, some use surveys, but the kind of unifying theme is looking at inequalities between different social groups and trying to understand how those health inequalities arise. So I'll leave that there and kind of now move on to the topic of today's talk, which is looking at gender-based mental health inequalities in primary care. So I just want to take a pause before I dive in and just make sure we're kind of all on the same page about some of the terms that I'll be using. So when we think about gender, we need to remember what the difference is compared to thinking about sex. So sex is something that has a biological interpretation. It's usually something that is registered at birth based on the kind of visible body parts of a baby. Related to that, but different, is gender or gender identity. And this is something that is socially constructed. It doesn't have an absolute. It's someone's kind of internal sense of whether they are a man or a woman, or anything in between or beyond those binary categories. So particularly in Western cultures, there's been a kind of very dogmatic idea that there are two genders, there's man and woman. And I think over the last few years, we're kind of gradually starting to recognise that actually there is much more gender diversity than that. And other cultures have recognised this for much longer. So there's a whole variety of terms that people use, and of course it depends partly which social groups you're in, where you live, kind of how old you are. People use different terms and the language is evolving. But there are some kind of umbrella terms we can think of. So terms that kind of cover a number of identities that are quite useful, and that's some of these terms I'll be using today. So for example, non-binary or trans or gender diverse. So what do we know about gender diversity in England? To be honest, not very much. And one of the big reasons for that is that there isn't actually any official formal legal recognition of non-binary or diverse genders. So obviously this has the effect of kind of marginalising people who are non-binary or gender diverse, but it also means we just don't really have any information about even the size of this population group or what their needs might be or any kind of outcomes. I think it's worth kind of pointing out that the UK is quite behind a lot of other countries on this. So there's a few countries up there that I've listed that now have official recognition of third or additional genders. So for example, you can have it on your birth certificate, your passport, or your official documentation. So kind of related to that, obviously one of the big ways that we count who lives in the UK is the UK census. So we just had one, you perhaps remember filling it in. There was quite a lot of debate about changing the questions on the census and including something to actually register what gender is everybody. But in the end, it was decided just to retain the binary question that asked about sex. So we still don't have any recording of gender in that context either. But the census did ask a second question asking about trans identity. So there was some progress there, and we now have a better sense of what the population is. So similarly, since 2004, when the Gender Recognition Act was brought in, trans people can now legally change their gender from one binary to the other, so from male to female or vice versa. But this remains quite a lengthy and intrusive process, and at least in England, it still requires a psychiatric diagnosis of gender dysphoria, so it's a very medicalised process. In terms of health and healthcare, there's no routine or required recording of gender in NHS records. So your NHS record will just have your sex. And there's no easy way or no kind of consistent way to record a trans identity in a health record. So a lot of computer systems just don't really have any facility to make that clear. It will just have to be written in kind of free text notes. So overall then, this whole picture is what gives us this lack of recognition and recording kind of across the board. And it means that we have almost no information about populations or health and health outcomes. So what about gender and mental health then? So although we don't have kind of big picture statistics, what we do know is quite a lot of information that's been found from kind of smaller studies or qualitative studies. So the kind of research where people interview people and kind of talk to people and ask about their experiences. So from this, we know that trans, non-binary and gender diverse people experience discrimination in England. And as with any marginalised group, like an ethnic minority group or other minorities, there is a risk of worse mental health outcomes because people experience the stress of being a minority and the stress of being treated and discriminated against. We also know that gender dysphoria, which is a sense of kind of discomfort or unease with the discordance between the sex registered at birth and gender identity, that can also increase the risk of poor mental health. Now, quite a lot of research has shown quite clearly that if people have access to gender-affirming healthcare, that can really resolve these mental health difficulties. But at the moment in the UK, it's really hard to get access to gender-affirming care on the NHS. There's long waiting lists, there's a lot of barriers, a lot of kind of hoops to jump through. So that is kind of potentially exacerbating these risks for quite a lot of people. So there's several things that might increase your risk of having a mental health condition, but people who have a mental health condition, if they are trans or non-binary or gender diverse, might also face difficulties trying to access appropriate mental health support. And there's been quite a bit of research into kind of experiences and why this might be. And there's kind of a few themes that have come out of that. So one is kind of a fear of or actual experiences of being discriminated against and the stigma associated. There's also, people are often concerned that their healthcare provider won't understand gender diversity. There's also the fact that, as I've said, people can't have their gender accurately recorded in their health records, so they feel kind of marginalised by the whole system. And there's fear and actual experience of healthcare providers pathologising people's identity. So I'm just going to take a moment to explain what I mean by that last point, just to be clear. So there's quite a complex and ongoing legacy of trans and non-binary identities being treated as mental health disorders. So it's actually only in the last few years that the World Health Organization removed being transgender as a mental health condition. So it used to be an international classification of diseases as a known mental health condition. Of course, you're probably all too young to kind of remember back to the 90s, but this has a lot of parallels with how other queer identities have been pathologized in the past. So it used to be that homosexuality was considered to be a mental health condition. And that used to be an international classification of diseases. So back in the 1990s, that was removed and that was updated and clarified. But there's an ongoing legacy from that even now. So even, 30 plus years later, it's only now that the government's trying and kind of thinking about introducing legislation to ban so-called conversion therapy for lesbian, gay and bisexual people. But again, in a sign of kind of how far behind trans rights are in the UK, the trans community will probably be excluded from this legislation. And similarly, as I mentioned before, in the UK, at least in England, to change your gender legally, it still requires a psychiatric diagnosis. So again, it's conflating identity with a mental health disorder. Okay, so that's a bit of a background of kind of just introducing the topic, but what were we trying to do in this study? So the first thing we wanted to do was estimate gender-based inequalities in the prevalence of long-term mental health conditions in England. The second thing we wanted to do was explore whether there are inequalities in mental health support within primary care, and to work with charities and people with lived experience to try and understand some of the wider context around this. So just expanding a bit on that last point, what we did was we worked with staff from the LGBT Foundation, the Proud Trust, 42nd Street and Made by Mortals. And this was working with people with a range of kind of lived experience and professional experience. And we held a series of kind of different types of meetings and discussion groups, and we talked about the context and also kind of the language that was most appropriate to use and how to kind of frame and report this sensitively in a way that felt kind of inclusive. I think I just wanted to emphasize this side of the research because you all are kind of starting out on your journeys into thinking about research and things. And I think it's increasingly something that's being done, and I think it's something that's really important, whether it's a particular community that you're doing research with and about, or whether it's a particular patient group or a particular type of medicine. It's so important to have that kind of patient voice or community voice and that lived experience, and to make sure that the work you're doing is truly inclusive. And you're not kind of doing research from an outside point of view about someone else, but you're doing research with whoever you're researching. So I've said a lot about how we don't have the information and nothing is recorded anywhere, blah, blah, blah. How did we do this? So what we were able to do is make use of changes to one of the big healthcare surveys. So up until 2020, the GP patient survey, which goes out to lots of GP patients every year, just asked about sex, so are you male or female? But since 2021, it now asks, which of the following best describes you, with options male, female, non-binary, prefer to self-describe or prefer not to say, and asks a second gender question, which is whether your gender identity is the same as the sex you were registered at birth. So this obviously gives us a much more complete idea of people's gender, and so we're able to use this to provide some of the first national estimates of mental health inequalities. So one of the other advantages of the GP patient survey is that it is absolutely huge. So over those 2 years, we had about 1.5 million respondents, and that means it's really useful for looking at minority groups. So although a low percentage of people identify as non-binary, we actually had quite a few respondents who did so we could still do the analysis. So looking at the demographics, then there are about 2,600 people who said they were non-binary, it's about 0.2%, and similar numbers who preferred to self-describe their gender. And then a slightly higher proportion who said that they would rather not say. In terms of cis or trans identity, the majority were cisgender, but there are about 8,000 people who are transgender, and again, a slightly higher proportion preferred not to answer that question. In terms of the two outcomes we were looking at, so the first was a long-term mental health condition, and about 9% of people said they had a long-term mental health condition. And then the other was having unmet mental health needs at your last GP appointment. So mental health needs is not going to be relevant to every GP appointment, but we first restricted this outcome to, it was about 40% of patients who said their mental health needs were a relevant factor at their last appointment. And then within that, about 15% of people said those needs weren't actually met. So it's a minority, but it's actually quite a few patients per appointment. So looking at a bit more detail at gender across the sample that we had. So we split into different age groups here, because we thought there might well be some generational differences. So what I'm showing you here is just, if you look down the side, that's each gender group, and across the bottom, it's the cis or trans identity groups. And in each case, the little number and the colour just gives an indication of how many people are in that group. So the darker colours just mean higher numbers. So if we look at gender diversity, which we can think of as kind of any groups who are not cisgender male and cisgender female, you can see that that's highest amongst the under 35. It's about 3% overall, and it's lowest amongst the oldest age group. What's interesting is that there's a relatively high proportion of people who prefer not to say to both the gender and cis or trans identity question. Now, there's probably a whole range of reasons for that, and this might be quite a diverse group in terms of, what motivated people to choose that box. But I think it's kind of important to remember that within that group, there might well be quite a lot of gender diverse people who don't trust the NHS with that information. So they didn't want to disclose their gender identity in an NHS survey. So it's really important to kind of look at outcomes for groups where you have missing data or not say, because there might be quite a lot of inequalities in those groups. One other interesting thing that you can see here is that you can see in the younger age group, there's far more people who are non-binary. And I think this is potentially reflecting genuine shifts in demographics, but also is likely to be partly about the language that people use to describe their gender. And that is, of course, shaped by your peers and social media and everything else. So it might be that identities are actually quite similar across generations, but the language that you use to talk about it is evolving. Okay, so before I get into the main results, I'm just going to give a little bit of information about the methods that we used. Please do put your hands up and stop me if anything isn't clear, because I don't want to lose you at this point. So we used something called a logistic regression model, which is not important, it's just the statistics that we did, to try and estimate the probability that for each group of reporting a long-term mental health condition. And then we did the same thing for reporting that your mental health needs were not met. What we did was we looked at each gender group, so that's the 5 gender groups, within each cis or trans identity group. So we had 15 groups overall to try and get this quite detailed picture. We adjusted by the age group and survey year, and that's just because we've already just seen that there's different gender profiles across the age groups, and on average, younger people tend to report a mental health condition more often than older people. So we just want to adjust out any differences based on that. We also then did something called mediation analysis, and I think you probably won't know what this is, so I'm just going to give a quick explainer. So, when we're doing this kind of statistics, what we're doing is we're saying, okay, we've got gender on one end, we can think of that as the exposure. Then we adjust for a couple of things that we think might be causing a difference, but we're not interested in, we just want to adjust them out. And then on the other end, we've got that causing the outcomes. But that on its own only tells us so much. So gender is not really likely in and of itself to be causing differences in mental health. In the same way that people being from different ethnic backgrounds is not likely to cause kind of inherently in and of itself the differences in health that we see in this country. What we need to know is what social stuff is on that causal chain between the exposure at one end and the outcome at the other. So we can think of these things as mediators. So in this case, one example would be, we know that people from gender minority groups experience discrimination. So that's going to limit the kind of socioeconomic opportunities they can have. It might lead to things like housing insecurity, employment insecurity, poverty. And we know that each of those things is a risk factor for worse mental health because they're major stressors in people's lives. So we can think of that as kind of completing this chain of events from gender at one end to mental health outcomes at the other. So mathematically what we can do, if we take those socioeconomic variables, if we take that information, add it into our model, if that is an important link on this pathway, we'll see the inequalities collapse down. So that's what we're looking for. As we add things in, do we see those inequalities reduce? So another one that we looked at was physical health. We know that trans, non-binary and gender diverse people face barriers to healthcare. And we know that physical health is really linked to mental health. And we considered this not really to be relevant to the first outcome, but we also looked at communication between healthcare professionals, so GPs and other doctors and other primary care staff, communication between them and patients, and whether patients reported that they felt they could trust and whether they had confidence in the healthcare professional that they saw. So we thought that might be one of the things on the pathway between gender and unmet mental health needs. So getting into the main results then. So this is first looking at the probability of reporting a long-term mental health outcome. So across the bottom here of the graph, we've got cis and trans identity. And then shown in the key there, we've got each of the gender groups. So what I'm showing is the probability of reporting a mental health condition. So the higher up the points are, the worse the outcomes for that group. So you can see there's some really wide inequalities here. For the groups with the kind of lowest probability of a mental health condition, it's hovering around kind of 10-12%. But for the group with the worst outcomes, transgender and non-binary people, it's close to 50%. There was also really high probabilities for trans patients who self-describe their gender, and for non-binary patients who prefer not to say their cis or trans identity. Looking across the groups, the inequalities aren't as large, but it tended to be higher for trans compared to cisgender patients within each of the gender groups. So then, looking at potential mediators, what's driving these differences? So first, we added in a load of health variables and said, is this to do with differences in physical health? So if you compare the two graphs, there's some reduction in the inequalities, but they look broadly similar. So we can say that perhaps a component of it is to do with physical health differences, but it's not a key driver here. We then added some socioeconomic variables, and again, it decreases a little bit further. So we can say that probably there's a component of socioeconomic inequalities, but most of the inequality remains there. So most of it is not explained by these factors. So we think probably that's because we don't really have stuff in the GP patient survey that really captures minority stress very well. And that's likely to be a big driver here. So moving on to the second outcome then, looking at unmet mental health needs. So here the probability of having unmet mental health needs was lowest for male and female patients who are cisgender. For all the other groups, there was higher probabilities of unmet mental health needs. Although across these other groups there wasn't really any statistical differences, there was a trend towards the highest unmet needs for patients who self-describe their gender or who prefer not to say their cis and trans identity. So again then, looking at what might mediate this. So first we added those same health and socioeconomic variables as we did at the last outcome. And you can see maybe there's a little bit of reduction here, but again, not really. We don't have the key drivers yet. But we then added in the communication and trust variables, and you can see that those inequalities have really collapsed down. For quite a lot of groups, there's no longer any statistical difference. So what we can conclude from this is that inequalities in the way that GPs and other primary care staff are communicating with their patients might explain a lot of the inequalities for trans, non-binary and gender diverse patients. So, to sum up what I told you then, in 2021, the GP patient survey became the first major health and care survey to have inclusive gender questions. We've used this to provide the first nationally representative estimates of gender-related mental health inequalities. In terms of inequalities in mental health conditions, we found that they were very much increased amongst transgender patients compared to cisgender patients and those who preferred not to say. We also found within that additional inequality for non-binary patients and for those who self-describe their gender. In terms of unmet mental health needs, we found increases amongst all gender diverse groups compared to cisgender male and female patients. And we found pretty good evidence that this is likely to be mediated by inequalities in healthcare professional to patient communication and relationships. You got it? Oh yeah. So these results, together with lots of that kind of previous evidence that I was talking about at the beginning, suggest some of the changes that are really needed to help improve these inequalities. So one key thing is we really need to improve the recording of gender in NHS health records. So we have this clear evidence now that this is not just some people, this is at a population level, we see these clear inequalities. But in order to kind of monitor and improve the situation, we need to have this recorded so that there can be more research and kind of audits and keeping track of things and making progress. One key thing to remember though is that this needs to be done in a way that, prioritises inclusivity and affirmation, but also keeps track of patient safety. So there are things where the NHS needs to know which sex you're assigned at birth in order to invite you for the correct things like preventative cancer screening. So for example, it's really important that your health record accurately reflects whether you have a cervix. At the moment, trans patients are often left without access to the right healthcare because they're faced with a choice of keeping the wrong gender marker or changing their sex marker. So it's these kind of things that we need new systems for and to try and make this work for patients. I think it's clear that we also need better training of healthcare professionals so that they can work well and confidently with all their diverse patients, not just certain groups. I think, improving communication and trust is really key to that. So there's a great program being run by the LGBT Foundation called Pride in Practice, and they're having some great results with training up people in primary care to be confident working with all kinds of patients. I think looking a bit more broadly, there's also a clear need for improved access to gender-affirming healthcare for people who need it, and broader still, an improvement in the kind of general legal and social environment for all trans, non-binary and gender diverse people. So I'll leave it there in terms of the findings, but just want to acknowledge all the public contributors who've worked with us along the way and the staff from each of the charities. Also, thanks to the team at the university who helped with the public involvement facilitation and the rest of the research team and the NHR funding. So I'll take any questions. Thanks so much.
Thanks, Ruth. I think we all really enjoyed that. Does anyone have any questions? Veronica?
So you mentioned some of your time in the US, especially in New York and Florida. So I was just wondering if there are any kind of health inequalities in particular that you found were more apparent in those areas, especially compared to the UK?
Yeah, I think being in New York, it's a city of extreme contrasts. You've got the ultra wealthy people there, and you have huge amounts of poverty. So I was working, it was the kind of the edge of Harlem, and Harlem it's a really vibrant, great neighborhood, but it also has some real poverty, and I think it's just very apparent in New York. I think it's probably, you could say the same of any big city, but I think the US, the extremes are just more extreme than we're used to seeing here, because there's less of that social safety net. There isn't an NHS. Some people just don't have health insurance and then they just can't have healthcare. And I think as someone who's used to an NHS type system and kind of, we can't call benefits generous at this point, but like some sense that there is a welfare state, to then be in New York is confronting. I think probably in a good way, because there's lots of it here. It's not as extreme and you can overlook it more, but yeah.
Good question. Anyone else? A question?
I have a statement to make rather than a question.
Ruth, you make me want to quit surgery and do public health.
Well, I have a question. As healthcare professionals, then what should we do then to quell this gap?
I think one of the things that you can easily all do, kind of every day kind of thing, is just reflect on each interaction you have with a patient.
Mm-hmm.
I think we're all human and there's people that we'll click with easily, there's people we relate to easily, but every patient deserves the same kind of time taken, the same thoughtfulness, the same kind of open questions rather than making assumptions. And I think probably that's the biggest thing you can do in a kind of everyday way, as well as kind of pushing for change and kind of, advocating for changes to medical education. There's also all the kind of, women's health, that side of gender equality. And I think there are a lot of big picture changes needed, but I think a lot of it also comes from each interaction with healthcare.
Great, thank you. That was very informative. It was very interesting. So, should we give a big round of applause to Ruth? We have a